we will briefly discuss those anterior abdominal wall, and this rectus sheath is related to this anterior abdominal wall. That's why you have to know all this, okay? See here, this is the section through the abdomen only showing the outer wall of the abdomen. On the posterior aspect, you are getting these vertebral bodies, lumbar vertebrae. These are paravertebral muscles, and these are flat muscles of the abdomen. From outside inward is the skin, superficial fascia. Superficial fascia contain two layers, fascia of Camper, fascia of Scarpa. Scarpa is fatty layer. Then external oblique muscle, internal oblique muscle, transversus abdominis muscle, then fascia transversalis, and then parietal peritoneum. And inside this peritoneal cavity, all the abdominal viscera are lying. Okay, understood? And anteriorly, these vertical muscles, these are the rectus abdominis, and this is covered by anterior lamina and posterior lamina, and these coverings are known as the rectus sheath. Okay, and rectus sheath's anterior covering is attached with the muscle through intersections to increase the power of the muscle, and posterior layer is free from the muscle, and there are neurovascular planes are lying here. Intercostal nerves are coming to enter into the rectus sheath to supply the rectus muscle, and they are entering from the lateral aspect. So we will discuss the rectus sheath formation at these three levels: above the costal margin, between the costal margin and arcuate line, and below the arcuate line. Okay, arcuate line is lying at the midpoint between the umbilicus and the symphysis pubis. Okay, around this level. So above the costal margin, this is a section above the costal margin. Here only anterior rectus abdominis muscle is lying over the costal cartilage. So posterior wall is deficient here. And anterior wall is formed by the external oblique muscle. Okay, and between the costal margin and arcuate line, there is both anterior and posterior walls are present. Anterior wall is formed by the external oblique aponeurosis and anterior lamina of internal oblique aponeurosis. These two are together forming the anterior wall, and posterior wall is formed by the posterior lamina of internal oblique aponeurosis and the transversus abdominis aponeurosis. So in some part there is muscle is present, and in some part only aponeurosis is present, and deep to it lying this fascia transversalis. Okay, this is from this level between costal margin and arcuate line, and below this level, below the arcuate line up to the symphysis pubis, all the layers are coming in front, all the muscles are coming in front of the rectus abdominis muscle, and posterior wall is also deficient here, or you can say posterior wall is formed by fascia transversalis here at this level. Okay, so external oblique, internal oblique, transversus abdominis, all are passing in front of the rectus abdominis below the arcuate level, arcuate line. Next. Okay, so here is the discussion. Above the costal margin, anterior wall is formed by external oblique aponeurosis, and posterior wall it is deficient here in this region, and the rectus muscle rests directly on 5th, 6th and 7th costal cartilages. Okay, next. Next, between costal margin and arcuate line, this is the formation. External oblique, internal oblique divides into two lamina, one passes anteriorly, one passes posteriorly. And third muscle is transversus abdominis, passing posteriorly. Okay, and in the midline, all the aponeurosis is fusing with each other and decassetting. The fibers are decassetting to form a midline structure, which is known as linea alba. Okay. So between costal margin and arcuate line, anterior wall is formed by external oblique aponeurosis, anterior lamina of aponeurosis of internal oblique. These two are together forming anterior wall. And posterior wall is formed by posterior lamina of aponeurosis of internal oblique and aponeurosis of transversus muscle. Okay. Next, see here, this is a section through the abdomen. This is umbilicus. Here is the Gifford process. Here is the symphysis pubis. Okay. So this is longitudinal muscle is the rectus abdominis muscle, and it was covered by this white fascial layer that is known as rectus sheath. Okay. So we have to cut the rectus sheath near the midline and have to reflect it laterally to prevent injury to the nerves which was entering from the lateral aspect. And these white lines over the muscle, these are the location of the tendinous intersections. Okay, intersections are connecting the muscle with this covering fascia. Okay, and it also helps in increasing the strength of the muscle. Okay, and during exercise you make six packs. Six packs are due to these tendinous intersections. Okay, there are four intersections are there. And laterally here you can see the internal oblique muscle. Here is the inguinal ligament which is forming the lowermost boundary. Next, and here you can see above the costal margin, this is costal margin. Here the external oblique is lying directly over the costal cartilages. Okay, next, here you can see the fiber direction. Fiber direction of external oblique is downward, forward and medially. Okay, like if you put the hand in your pocket, downward, forward and medially, this is fiber direction of external oblique. That's from the fiber direction you have to identify the muscle. Okay, they're very thin muscles, like you have seen in your thorax, slightly thicker than the intercostal muscles. Okay, so external oblique muscle, it is forming the aponeurosis here and forming the rectus sheath near the midline. Next, so this is the location of external oblique. Here is the internal oblique. External oblique was originating above from the costal cartilages and ribs and inserting over the iliac crest. Internal oblique is originating below from the iliac crest and it was inserting above. And transversus abdominis, it is originating from iliac crest and some part also from this costal cartilages. Okay, and forming the aponeurosis. So these are the locations of these three flat abdominal muscles: external oblique, internal oblique, transversus abdominis, and this is the rectus abdominis muscle. Okay, and these white lines are the tendinous intersections. Four intersections are present. Next, see here, this is midline. In the midline there is linea alba, and the two sides of this midline, this longitudinal muscle is the rectus abdominis muscle. That's why the name is given. Rectus means straight and abdomen means it is lying straight over the abdomen. And here near the symphysis pubis, another small muscle is present. That is also a content of rectus sheath, that is known as pyramidalis. Okay, originating from the pubic crest. And this is posterior surface of the rectus sheath, which is and posterior surface of anterior lamina of the rectus sheath. Here you can see the positions of the intersections. Next, these are the positions of different intersection. One is located at the level of Gifford process. Okay, one is located at the level of umbilicus, and third one is located in the midpoint between the Gifford process and umbilicus, and fourth one is sometimes present, it is lying below the umbilicus. Okay, understood? These are the locations of intersections. Rectus sheath can come as a long question. You will be asked your formation, content, intersections. Okay, all these you will be asked. And why the rectus sheath is reflected laterally? Because to prevent injury of the nerves. Okay, because nerves are entering the rectus sheath from the lateral aspect. This is one important explain why question. Next, these are the rectus abdominis muscle and intersections, and these are the flat muscles of abdomen. Next, okay, so this is umbilicus, rectus abdominis muscle, intersections, external oblique has been shown. Here is the muscle portion, and this white portion is the aponeurosis portion of the external oblique. Next, aponeurosis of external oblique muscle and anterior lamina of internal oblique forming the anterior wall of the rectus sheath. Next, okay, muscles has been cut. Flat muscles, outer one is external oblique, then internal oblique, then transversus abdominis, and this is rectus abdominis, and in this region lies the pyramidalis. Here is the inguinal ligament, and the midline is the linea alba. These are the tendinous intersections. Next, this is the formation. You practice a schematic diagram like this. Okay, external oblique converted into aponeurosis forming anterior wall. Here, internal oblique dividing into two aponeurosis, anterior and posterior lamina. Anterior is going anterior to rectus abdominis, posterior is going posterior to rectus abdominis, and transversus abdominis lying posteriorly. Okay, and below the arcuate line, all the muscle layers are lying anterior to rectus abdominis, and above the costal margin, only external oblique is forming anterior wall. Next, these are the contents. Contents are the rectus abdominis muscles, pyramidalis muscle. If present, this small triangular muscle is the pyramidalis muscle. Okay, it is sometimes absent. Almost 40% cases it is absent. Pyramidalis muscle, and there are vessels and nerves. Nerves are the intercostal nerves. Here you can see these are the intercostal nerves entering into the rectus sheath, and vessels are the superior and inferior epigastric vessels. Superior epigastric vessels was coming from thorax. It is the one of the terminal branches of internal mammary artery. Internal mammary was dividing into musculophrenic and superior epigastric. So superior epigastric enters into the rectus sheath, posterior to the muscle. Okay, and inferior epigastric was coming from below, and they are anastomosing with each other within the rectus sheath. Okay, so this is content of the rectus sheath. These are the vessels, and nerves are the intercostal nerves. Okay, understood? Next, this is the region of inguinal ligament. External oblique aponeurosis has been reflected. Okay, to show the different nerves, ilioepigastric, ilioinguinal. This is ilioinguinal nerve, iliohypogastric nerve. These are also partial content of the rectus sheath. Okay, understood? This is pyramidalis muscle, linea alba. Pyramidalis is originating from the symphysis pubis and the pubic crest, and it is inserted, apex of the muscle is inserted into the linea alba. Okay, so this is location of pyramidalis. Next, pyramidalis and rectus abdominis intersections. Okay, okay, next. Rectus strengthening of rectus muscle is done during the abdominal exercises. Okay, these are the intersections. Next, six packs formed due to strengthening of the rectus abdominis. Next, okay, and another thing, during childbirth, okay, during pregnancy, there is distension of the abdomen. So rectus muscles are they are separated from each other. Okay, the distance between the muscles are increased, and strength of the muscle is also uh, lost. So after recovery, there is high chance of hernia in case of females. After the recovery from pregnancy, there is high chance of um, separating of these two muscles, that is known as rectus divericans. Okay, in this case, two muscles will separate from each other and abdominal content can herniate from the midline. Okay, there is no other structure over the abdomen, there is no bone, only fascias are there. So there is high chance of a hernia from this midline. Next, so anterior abdominal wall, muscles of anterior abdominal wall play a major role in movement of the trunk. They are protecting the abdominal organs, increase the intra-abdominal pressure and aid in expiration and all the straining activities such as micturition, coughing and vomiting. This function is asked in your viva. Okay, all these functions of the abdominal muscles supplied by lower 5 intercostal and subcostal nerves. Next, so strong abdominalis are important in helping in to stabilize the trunk. They also stabilize the trunk because they are connecting the costal margin with the iliac crest. So that's why they stabilize the trunk. They support the spine and they flex and rotate the trunk. Acting from one side or acting from two sides, they twist the trunk and they flex the trunk. Acting with the adductors and abductors of the hip also helps in adduction and abduction of the hip. And they help to stabilize the pelvis during walking and running. So all these are functions of anterior abdominal wall muscles. Next, after the muscles, there will be superficial fascia. Superficial fascia have fascia of camper. Camper is the fatty layer, and fascia of Scarpa. Camper and Scarpa. Scarpa is the membranous layer. These are part of the superficial fascia. And below umbilicus, it is superficial fascia is continuous with the collis fascia in the perineum. Okay. Next, lower 5 intercostal nerve and subcostal nerve is the root value T12. They are supplying the anterior abdominal wall muscles and supplying the skin also. Dermatomes are present. Okay, T10 dermatome is lying near the umbilicus. That's why in abdominal, in appendicular infection, there is pain is referred towards the umbilicus. Okay, because same nerve supply, visceral supply of appendix is coming from this T10. Okay, that is also important. Explain why question, why referred pain is going towards umbilicus in appendicular infection. Iliohypogastric nerve, L1 and ilioinguinal nerve also supplying the anterior abdominal wall. Next, intercostal vessels are also lying. Skin above the umbilicus, there are superficial veins and lymphatics drained into the axilla. And so level of umbilicus is known as watershed line. Okay, watershed means one division line. Above it other supply, below it another supply. Okay, that's why watershed line. So skin above the umbilicus, superficial veins and lymphatics drain to the axilla, and skin below the umbilicus, superficial veins and lymphatics drain to the long saphenous vein. Great saphenous vein is again draining into the femoral vein, and superficial inguinal lymph nodes are present in the superficial fascia near the inguinal ligament. Next, so inguinal lymph nodes, their proximal group is lying parallel to the inguinal ligament, and they are enlarged and tender inguinal glands occur in case of some lymphadenopathy or in case of any infection of the lower limb or perineum. Okay, and secondary deposit also occurs in some cancers. Next, inguinal glands, proximal group lesions in the local structure may lead to proximal group enlargement. skin of the lower abdominal wall, gluteal region, and skin of the scrotum and labia. Here infection occurs. They will go to distal superficial glands. Distal superficial glands is like the great saphenous vein. Skin of leg area is drained by long saphenous vein and all drain to the deep inguinal glands along the femoral vein. Okay, understood? Next, so this is lymphatic drainage of the lower part of the abdomen and the lower limb. So abdominal muscles are, these are the muscles. So these are the formation and content. These flat muscles are forming the rectus sheath, and these are the contents: rectus abdominis muscle, pyramidalis, nerves and vessels. And nerves and vessels are lying between internal oblique and transversus abdominis. That is important. Neurovascular plane of the abdomen is lying between internal oblique and transversus abdominis. Okay, understood? Next. You have read the origin, insertion, nerve supply, action of all these four muscles, external oblique, internal oblique, during anterior abdominal wall class? Yes or no? Otherwise, I will discuss it. Okay, I am discussing it briefly. So, external oblique origin is from above, outer surface of lower border of lower 8 ribs, interdigitating with serratus anterior and latissimus dorsi, and fibers pass medially and inferiorly. Okay, so this will be the fiber direction, downward, forward, and medially for external oblique. Next, inserted into the anterior half of anterior two-third of outer lip of iliac crest. Okay. Aponeurosis in the inguinal region passes anterior to the rectus muscle, forms the inguinal ligament. Inguinal ligament is formed by thickening of the aponeurosis of external oblique. Okay, you know it. And extension from this inguinal ligament is lacunar ligament, triangular extension near the midline. And reflected portion of inguinal ligament, that is also extension from the inguinal ligament. So all these are formed by external oblique. Next, inguinal ligament, how it is formed? Aponeurosis of the external oblique is folded back from anterior superior iliac spine to pubic tubercle to form the inguinal ligament here. From anterior superior iliac spine to pubic tubercle. Okay, and this is lacunar ligament. This triangular extension from inguinal ligament is lacunar ligament, and here lies the reflected part of the inguinal ligament. This is black portion is lacunar ligament, and here is reflected part. Lacunar ligament is triangular attached to the pectineal line, and lateral free border is forming the medial margin of the femoral ring. Femoral ring you have read during femoral sheath. Okay, so lacunar ligament was forming a boundary of the femoral ring. Next. So insertion of external oblique occurs in the pubic crest, gap for superficial inguinal ring, pubic bone, linea alba, anterior wall of rectus sheath, and Gifford process. Here it is inserted. Next. Acting separately, the external oblique flexes the vertebral column laterally and rotates it to the opposite side. And if the thorax is fixed by contracting both the external obliques, you can tilt the symphysis pubis superiorly and flex the trunk. Posterior pelvic tilt helps in posterior pelvic tilt. Movement of the iliac crest determines the direction of the tilt. Okay. Next. In next we go to internal oblique. There is muscular origin lateral from the lateral two-third of the inguinal ligament. Okay, we have discussed external oblique is originating upward, coming downward to inserted in the iliac crest. Internal oblique is originating below from the iliac crest, inserting above. Okay, so anterior two-third of intermediate lip of iliac crest. Lumbar fascia and muscle fibers arch over the content of inguinal canal anterior to the rectus muscle, forming the conjoint tendon, and fibers pass medially and superiorly. Okay, next. Into the costal margin, insertion of the internal oblique into the costal margin, upper 3 as fleshy fibers, next 3 as aponeurotic, inserted into the linea and between the gyphoid process and halfway between umbilicus and pubic symphysis, aponeurosis splits, okay, to enclose the rectus abdominis muscle, forming the rectus sheath. An anterior layer fuses with the external oblique, posterior layer fuses with the transversus abdominis. Okay, understood? Next, now this is formation of the conjoint tendon. Halfway between the umbilicus and pubic symphysis, aponeurosis of internal oblique and transversus abdominis fuse to form the conjoint tendon. Anterior portion of rectus sheath is inserted into the pectineal line behind the superficial inguinal ring. So, all these are insertions of the conjoint tendon. Anterior, it is inserted over the anterior portion of rectus sheath and inserted into pectineal line behind the superficial inguinal ring. Next, the right side of the muscle twists to the right and the left side twists to the left. The lower 6 intercostal nerves are supplying the muscle and subcostal nerve and iliohypogastric nerves are also supplying. Next, we go to transversus abdominis muscle. Origin is from lateral 1/3 of inguinal ligament, anterior 2/3 of the inner lip of the iliac crest. Lumbar fascia, lower border and inner surfaces of lower 6 ribs interdigitating with the diaphragm. So these are the site of origin of transversus abdominis. Okay. Next. So in transversus abdominis is originating both from above and downward and inserting, it is passing transversely and inserting into the midline. Insertion into gyphoid process linea alba, okay, halfway between the umbilicus and pubic symphysis, fuses with the posterior lamella of internal oblique and below it forms the conjoint tendon with the internal oblique and inserted into the pectineal line behind the superficial inguinal ring. Okay, so this is the disposition of transversus abdominis. Next, how it acts. It helps to support the abdominal viscera, maintain intra-abdominal pressure, stabilize the lumbar spine, and it is supplied by lower 6 intercostal nerve, subcostal nerve, iliohypogastric nerve. Okay, so you have to identify these muscles. They can be given in your OSPE, and you have to write down the origin, insertion, nerve supply, and action of these muscles. Okay, so these 4 muscles are important for your OSPE. Next, rectus is also given in OSPE. Okay, pyramidal is, it is rarely present. If present, can be given in OSPE. So rectus abdominis, it is a segmental muscle. It has 2 heads. One is originating from anterior part of pubic symphysis. Another is originating from pubic crest and inserted into the anterior aspect of 5th, 6th, 7th costal cartilage. Not costal cartilage, it is inserting into the mainly into the linea alba, and through the linea alba it is attached to these cartilages. Adhesions, anterior surface, uh, over the anterior surface is present, and segmental blood supply and nerve supply. Oh, okay. Oh, we are discussing rectus abdominis, so it is inserted anterior aspect of 5th, 6th and 7th costal cartilage on each side. Okay, and adhesions are present over the anterior surface. Adhesions means this tendinous intersections we are referring. Segmental blood, there is segmental blood and nerve supply from the intercostals and the rectus abdominis flexes the trunk. Next, see the rectus muscle are the most powerful flexors of the vertebral column. And when we raise the head from a supine position, a movement often used to strengthen this rectus abdominis muscle. Okay? And it is the recti that contract first when we raise the trunk from supine position. And when the shoulders start to rise upward, the obliques start to contract. Next, okay, so rectus sheath. Today in this section, we will see the rectus sheath. Okay, so you read, go home and read this formation of rectus sheath right now. Okay, so above xiphoid, anterior wall is the external oblique, posteriorly only costal cartilages, posterior wall is deficient. From xiphoid and halfway between umbilicus and pubic symphysis, anterior wall is formed by external oblique and anterior lamina of internal oblique, and posterior wall is formed by posterior lamina of internal oblique and transversus abdominis. Next, and below the halfway between umbilicus and pubic symphysis, the aponeurosis of external oblique, internal oblique and transversus abdominis, these two internal and transversus forming the conjoint tendon and pass anterior to the rectus abdominis, and posteriorly it is lies over the fascia transversalis. Okay, understood? So here also posterior wall is deficient. In the middle part only posterior wall is present, and the lower margin of this internal oblique at the midpoint between the umbilicus and the symphysis pubis, one semilunar margin is present. Okay, that is known as arcuate line. Next, what are the contents? Contents are the rectus abdominis muscle, pyramidalis, superior and inferior epigastric vessels, lower 5 intercostal vessels and nerves. Okay, so all these you have to see. This may not be clearly seen. Pyramidalis, if present, you have to see. Okay, so these are the contents of the rectus sheath. Very frequently asked question, very important OSPI question, also given in your theory. Next, fascia transversalis lies on the deeper aspect of transversus abdominis, fuses with the inguinal ligament, continuous with the iliac fossa, except in the region of femoral vessels, and forms the anterior wall of the femoral sheath. Okay. Next. Next we go to, so we are discussing from anterior to posterior, skin, superficial fascia, then 3 muscles, then fascia transversalis, then extraperitoneal fatty tissue. Extraperitoneal connective tissue, it is fatty, it separates the fascia transversalis from the peritoneum, from the parietal peritoneum mainly. If thin, they are in close contact with each other. Okay. Next. So if the extraperitoneal fatty tissue, it is very thin, then the peritoneum and the fascia transversalis will be close to each other. Okay. So next we go to parietal peritoneum. There are some pouches in the peritoneal cavity. So peritoneal pouches are found in the region of deep inguinal ring, medial portion of the posterior wall, and posterior aspect of the anterior abdominal wall. Also there are some peritoneal pouches. Okay. So peritoneum will be discussed separately in your lecture also, and also you will be shown it in your dissection.